The title of today's presentation is Effects of Metabolic Disorders on Dairy Cow Health and Reproductive Performance. Dr. Oetzel, thank you.
Thank you very much, Mr. Chairman. It's an honor to be invited to this meeting. I thank the organizing committee. It's a pleasure once again to be in Hokkaido, which is a welcoming and wonderful place for me to visit. So today, we're going to talk about quite a few things: hypocalcemia, ketosis, hypomagnesemia, and hypophosphatemia. I'm not going to do great detail on all of those. I have a very detailed proceedings paper. Perhaps you've looked at that. You'll be relieved to know I'm not going to cover all of those things. And what I'm going to do today is to hit highlights of things that are new and even some of the more controversial things in these areas. And I'll spend most of my time actually on hypocalcemia in cows. So it's a disorder that we are largely, I think everyone in this room would be familiar with this problem. Now, before I go into that, I want to talk a little bit about the dairy cow. We know that cows are metabolic athletes. Their energy demands, which we understand well are very high, reach about 5 times maintenance. So I took the numbers from the National Research Council guidelines in the United States and looked at that, and a typical sized dairy cow has a maintenance energy requirement of 10.3 megacals of net energy for lactation. If she peaks at fairly high production, a little over 54 kilos or 120 pounds of milk, very common for us, that adds another 38 megacals of energy. So the total is 48.3 or 4.7 times maintenance. There are very few animals in nature that can sustain that sort of effort. That would be like us running 2 marathon races every day. It's the same energy outflow. But I want you to think of calcium as being of similar problems and a similar challenge to dairy cows, and it's just a little less, or about 4 times maintenance, because maintenance is 21 grams. That 54 kilos of milk is another 67 grams. The total's 88, or 4.2 times maintenance. So cows are calcium athletes as well as being energy athletes. So it's no wonder we get in trouble with calcium metabolism, especially since, we're going to get to 67 grams of calcium, but 20 to 30 grams of that calcium happens in about a 1-day period right before calving, as they excrete that much calcium in the first colostrum that they produce. So things go wrong with calcium. We're familiar with clinical milk fever. By definition, a cow that becomes recumbent and has a low calcium. In the United States, the incidence of clinical milk fever is declining. We do a national survey in the United States every few years. The 2002 data said 6.2% clinical milk fever in lactation 2 or greater cows. The 2007 survey, we dropped to 4.9. The herds that I work with, which tend to be a little larger, very well managed herds, always below 2% clinical rates. Almost never see it higher than that amount. So clinical milk fever has gone down, even as production has gone up. We've done something right. And it's nutritional management, it's environmental management, it's anionic salts in some parts of the world, but we've brought this clinical rate down. I think we all would understand that clinical milk fever is going to cause problems for the cows. So we show you 3 studies where we've looked at these things, and we'll look at a series of outcomes for that. So the first study that got us going on this came out of New York, a little over 2,000 cows. And if they had clinical milk fever, they had a 4.3% incidence of clinical milk fever in the study, typical for that time. Any dystocia was about 3 times increased odds. A severe dystocia was almost 7 times. Retained placenta, 3 times increased odds if they had clinical milk fever. Ketosis went way up, and that establishes this link between calcium metabolism and energy metabolism, because these hypocalcemic cows do not eat well. and they do not get off to a good start, and then they get into energy trouble as well. Left displaced abomasum, 3.4 times greater odds. Many studies since then, they all hit around 3 times greater risk for displaced abomasum. Following hypocalcemia, even clinical mastitis went up in that particular study with hypocalcemic cows, probably because they weren't closing the teat sphincter or may have been recumbent. A later study out of New York, 2.6 times increased odds for dystocia, very similar. Clinical ketosis a little lower, LDA a little lower, but we're still seeing consistent effects on a very large study, almost 8,000 cows. A more recent study out of Quebec looked at herd removal, and it was a 1.9 times increased risk for herd removal, as we would expect in cows with clinical hypocalcemia. Those are the down cows. But what about the cows that are not down? And this is the hot area of hypocalcemia research today. So subclinical hypocalcemia, which we're going to define very carefully. It's low blood calcium around the time of calving without recumbency. It's not very well named because these cows may show clinical signs if you look closely enough. They may be a little bit wobbly. They may be shifting their weight a little bit. They may have a dull appearance. They may have cold extremities or even be hypothermic if we take their temperature. They may have reduced ruminal contractions or a very mild tachycardia. So we call it subclinical, but under careful observation, there may be some clinical signs. The point is they're not recumbent. Okay, there's some research on this. In fact, the most predictive signs in a Greek study were heart rate over 100 beats per minute and 1 or less rumen contractions per 2 minutes in cows that had subclinical hypocalcemia. The problem is in the field, neither of these are very practical tests, at least for producers to do, because they take time, and most of our producers are not skilled even at getting a heart rate in a cow, let alone listen for 2 minutes. But it doesn't surprise us to see this. Ear skin temperature has always interested us. In a German study says that yes, it's lowered in some cases, but it's greatly confounded by ambient temperature and simply not reliable for diagnosing that. So it is present in some cases, but not reliable enough and very confounded. So how much of this subclinical hypocalcemia do we get? I'm going to point to 2 very large studies, and I'm going to look at the risk by parity group of cows, which is very, very important. The first one will be from one of our NAMS studies, these big surveys we do in the United States. I should say that's the National Animal Health Monitoring System. And in this study, they took a subset of those cows and actually collected a blood sample. These are randomly selected herds, so a very powerful study design. Sample was collected at 0 to 48 hours after calving, and the threshold for what they described as subclinical hypocalcemia was less than 2 millimoles per liter, and this was total calcium. So in this study, we're going to show you the risk for subclinical hypocalcemia, and I'm really not interested in the aggregate risk because, as you could see from these data, these numbers are very, very, very dependent on the parity group. So first calf heifer is at 25, which surprised us. They have an active growing skeleton. We would think they would not be as vulnerable. They certainly get very little clinical, but they are getting some subclinical in this study, and then it just goes up and up and up as the cows get older. The bones become more refractory to mobilizing calcium as the cow ages, and the cows are also producing more colostrum as they get older. A similar and very nice study was done in Germany and was recently published, also very large, a lot of cows, a lot of herds, exact same cut point and the exact same time of sampling. They had only 6% in first lactation, which is less than what we have in the US cows. And it got really bad in the older cows, up to 60% of the cows showing or meeting this definition for subclinical hypocalcemia. So there's a lot of this out there. We have not had many surveys over time. It's our impression that this is clearly not going away. And if anything, the amount of this may be going up in our herds. So we've done well with clinical, but not so well in preventing the subclinical. However, I'm going to go through a series of problems now because subclinical hypocalcemia is not easy. And the study results are somewhat inconsistent. I showed you probably the two consistent ones, and every other study is going to vary a little bit. They may exclude clinical milk fever cases, okay? Usually it's not very many, but that will affect the numbers. Some studies have excluded very low blood calcium, less than 1.25, just saying, oh, they should have been clinical, and we just don't put those in. We probably shouldn't do that. Some studies do total versus ionized. Both are possibilities. Timing of sample and the cut point used. And I'm going to talk about all of those last ones in some detail because there's a lot of interest in dealing with subclinical hypocalcemia. Let's do the total versus ionized first. Now we ought to say right off, we know ionized calcium is the active form. It's the most biologically relevant, but it's more expensive. Going to require anaerobic sample handling unless we go with a calcide test, which is nice. This is one example of a test for that. This is the ISTAT test. But this is expensive. It's an expensive calcide meter and expensive cassettes to run that. We are working, and we just meaning academia in general, or Dr. Nevis, who's sitting out here, has worked with a new ion-sensitive electrode. Actually, it's been around for a while to analyze water samples. Has not worked particularly well for blood. It's done okay. It's still in the prototype stage, and we would only recommend it for semi-quantitative use. And you'd say, well, if we can use this for water, why can't we use it for blood? There's more calcium in most of the water that we drink than circulates in the blood in millimolar concentrations. It's an extremely small amount of calcium. So maybe there's 8 grams in a cow's whole body circulating in the fluid. And I say, of course, that's the most important, 8 grams in her whole body, because that's what I like to work with. Okay, so we would love a rapid calcide test. Maybe that will work out in the future. So let's go to total calcium, which is more practical. Now we know it includes calcium that's bound to albumin or other proteins. We know it can be complexed with anions, so it can be affected by blood albumin concentration, other proteins, or blood pH. However, we're dealing mostly with normal cows who do not have disturbances in these other metabolites, and it tracks pretty well. So most of the data we're going to show you are based on total calcium. Recognizing ionized would be better, but it's inexpensive, requires no special sample handling as long as we collect our blood tube, but it's definitely not calcide at this point. We don't have that option available. Now, we're very interested in this relationship of total to ionized, and one very nice new study, recent study, said that they're not interchangeable. And you can't just take the ionized and double it and say that's your total. In fact, the proportion of ionized to total calcium changes by days in milk. Cows on the day of calving, 56% of their total calcium is ionized. At 5 days in milk, it was 60. That makes a difference. So as we continue to work on this and develop technologies to measure these things, we're going to need to have independently developed cut points for ionized calcium compared to total calcium. We're not going to be able to relate one to the other one directly. Time of sampling makes subclinical hypocalcemia very interesting. The traditional, original approach was to sample around the nadir, which would be about 12 to 24 hours post-calving. That's when they hit the lowest point. I like to say to producers, it's not the first colostrum that does the most damage to the cow. It gets her set up. It's 20, 30 grams of calcium outflow that came out of nowhere. But 8 to 12 hours later, she's going to do that again. And another 20 or 30 grams is going to come out. And then they finally start to eat and demobilize some body calcium. So it hits the low point here, and we thought that made sense to test there. And so many studies have done that, and I've done that in studies, and that was our starting point. There are problems with that. And we're going to show you that none of these are perfect. But first of all, there is a biological concept that some hypocalcemia is necessary to initiate calcium homeostasis. A good dairy cow is going to have a slight drop in her blood calcium. Otherwise, she will not bring out parathyroid hormone. She will not upregulate vitamin D, and she will not respond to what she has to, which is to mobilize a tremendous amount of calcium from her body up through the first roughly 2 or 3 months of lactation. They have to have some. Now, we don't want them to go too low. I'd prefer they not go below normal, but we know that it's out there. It may be confounded by inherent milk yield. In higher producing herds, may have a little more subclinical hypocalcemia just because there's more milk flow. And perhaps more importantly, it's not as predictive of subsequent health and performance as would be calcium sampled a few days later. We're going to develop that concept quite a bit. But before I go into those later sampling days, I want to make what I think is an important point. Sampling around the nadir, day of calving or day after, in these studies is associated with negative outcomes post-calving. And this is in the literature, and we have to understand there is value in sampling at this time. Elevated NEFA and liver fat post-calving. There's a study that shows that. Calcium was sampled on the day of calving. Decreased rumination time is associated in another study with that. Increased risk for RP, metritis, displaced abomasum, ketosis, and early lactation culling have all been shown in different studies on samples taken right around the nadir, the day of calving, or maybe the day after that. Other studies have shown no effect of subclinical hypocalcemia when measured around the nadir. So we have to acknowledge that that is happening as well. So what do we do with this as we think about sampling? So sampling around the nadir is the only way we're going to evaluate the effect of diet on the risk for subclinical hypocalcemia in our herds. We can't wait to do that, because if we wait till day 2, 3, or 4, disease events are confounding our results. So cows are already developing other clinical problems with secondary hypocalcemia associated with them. So if we want to get a clean look at how the diet is performing in a herd, we have to sample around the nadir. And that is going to stay the same. That's what we are going to do. We are doing this in some of our well-managed, high-producing herds. And we're most interested in how this herd changes in the prevalence of subclinical hypocalcemia over time. So we answer the question, does our diet work, by sampling at this time? The thing we have to do to really make this work is we've got to adjust for parity. It won't be hard to do, but we haven't formally implemented this yet. Because herds with a lot of young cattle are going to have different numbers than herds with a lot of old cows. And I think we can pretty simply make adjustments. We just haven't brought that to the field yet. So it is true and important in a more recent and very exciting discovery that subclinical hypocalcemia is more associated with negative outcomes if we go past about 48 hours post-calving. So many studies have shown this. They're all very recent. So cows that had persistent subclinical hypocalcemia in a New York study, meaning they were low on days 1, 2, and 3. And what we've seen in general is if a cow's low on day 3, she was almost automatically low on day 2 and low on day 1. Very unusual for that not to be the case. And that was a much better predictor of impaired reproductive performance than blood calcium on day 1 or 2. So this study got us going down that path. So predicting negative outcomes, it's nice to sample later. Another study out of Florida that really got us excited on this was anytime they had subclinical hypocalcemia, testing out to day 3 was associated strongly with increased risk for metritis, explained by lower neutrophil counts, explained by impaired neutrophil function. Cows also had increased NEFA and increased BHBA if they were hypocalcemic, but they extended the testing out to day 3. Okay, another very large multi-site study showed that when they were sampled any time in the first week, that hypocalcemia was associated with increased risk for displaced abomasum, decreased first test milk yield, and decreased risk for conception at first service. And then a reproductive study where cows were sampled out through 3 weeks. And during that time, if they were hypocalcemic, it was associated with a number of impairments of reproductive performance. Then I want to show you a new study, which is in press. because I think this is exciting, and this study pulls together concepts that I've been talking about and illustrates these key principles. So 396 Holsteins in 2 herds, 35% first lactation. They were included in the study. We'll show you some of their data. With total calcium on day 1, 2, 3, and 4 after calving, with no sample taken the day of calving. So that was the setup for this study. So now we get a really nice look at what happens here. And Raphael will recognize these data. But here we go. They pooled together metritis and displaced abomasum risk. We're going to show you the model for the 3rd and greater lactation cows. And calcium on day 1, 2, and 3 was not associated with increased risk for those diseases. But at day 4, it was. They modeled the cut point. The cut point was anything less than or equal to 2.2. That was 43% of these old cows. It's a pretty high cut point. So a lot of cows are affected. They're 3.1 times more likely to develop metritis or displaced abomasum. There's your confidence interval, does not overlap 1. Sensitivity and specificity are surprisingly good because we're measuring calcium to predict diseases that we might think ostensibly are not related to calcium, but in fact, they're quite related to calcium. Same situation, model that for the 2nd lactation cows. Day 1 was not associated. Day 2 was. This is an interesting one, very low cut point at below less than or equal to 1.97, so only 20% of the cows, but 4 times greater risk for metritis or a DA. Confidence interval sensitivity was a little lower on that one. So it's a little hard to predict where this is going to fall, right? And it's not going to be terribly consistent, yet there's some biology here that's really important. And I'm really glad they included the first lactation heifers in this study. On the day after calving, there was no relationship between hypocalcemia and metritis. Here they just did metritis because we get a lot of metritis in our first calf heifers. And it was associated with hypocalcemia for day 2, 3, and 4. The cut points were about the same. And all these had a similar relative risk, but the longer they stayed hypocalcemic, the more likely they were to have metritis, up to a relative risk of 6.1. Very high sensitivities and specificities. So heifers don't often get hypocalcemic, but when they do, they're at very high risk for metritis. And especially if it's a little later in days in milk. These are lovely and important discoveries. Then what about milk yield? And milk yield is something that we've understood related to subclinical hypocalcemia. It's confounded us from when I started working on this. Because here on the day after calving, hypocalcemia, the derived cut point was less than 1.77, 23% of the cows. Milk yield was positive. And if you look calcium around the nadir, many other studies show this. The lower the calcium, the more milk. So does hypocalcemia cause increased milk yield? No. How about the other way around? High milk yield causes more hypocalcemia. That's on day 1. But our suspicion was if that hypocalcemia persisted, this would go the other way. So thank you guys for showing us this. Day 4, the cut point was pretty high, less than 2.2. 39% of the cows were affected, 1.75 less kilos of milk per day. And this was looking at 15-week milk. So that's looking at milk over a nice long time period. A very nice principle here to see that. And then finally, we're going to show you the heifer data from this study. So in the primiparous cows, it was only predictive on day 1, kind of like it was for the cows, because it was positive if the heifers were hypocalcemic. They gave a little more milk, and they didn't see any persistent things, probably because there aren't a lot of heifers that get persistent hypocalcemia. So a lot of new data, a lot of nice things going on here. But what about the cut points? This is confusing. So we used 2 in the early literature because it kind of made sense. It was a nice round number. People ask me, I used it in one of the first published studies on subclinical hypocalcemia. Where did you get that number? I made it up. And that's just what we tell people. We made it up. It wasn't derived. And many studies have done these predetermined cut points, which is all we had initially. Now we know a little better, but I've seen everything from 1.95 to 2.15. What we ought to do is use cut points expressed in terms of an outcome. The problem is they're going to be a little different, and in the end, we're going to have to come to some agreement on some cut point, perhaps, based on disease. But here's some new ones that have come out, and you see, less than 1.85 for DA, ketosis similar. Here's another DA study that had one a little bit higher. All right, if you're not confused about cut points, you're not paying attention. It's confusing out there. I want to say some good things about cut points, and I want to make a proposal for a different way to look at these. Okay, first of all those cut points I showed you, that's a pretty narrow range. It's not precise, right? But it's pretty narrow range, and they're all below normal, because most would agree that below about 2.2 would be our normal range. Okay, that part's good. Pretty narrow range, etc. But it frustrates all of us that are working in this area trying to understand this disease. So I'm proposing an alternate approach that we use multiple cut points for this whenever we evaluate a herd. Have to use appropriate multiple alarm levels, alarm level being when we decide it's bad, okay? And then just essentially do them all. So when I do these, I run multiple cut points whenever I test a herd from 1.75 out to 2.15. Now this makes a big assumption. The assumption is that when the calcium gets lower, 2.15, 2.1, 2.0, that it is worse for the cows, that every increment means it's worse. And thankfully, the study that Rodriguez and his workers did showed that that's true. And that was the first time I saw that, and that was very important to have that. It makes sense intuitively, but now we have it. Okay, so I'm going to go to my data, which is unpublished. We're continuing to develop this, but I'm wanting to show you a concept. So I've got data from 63 herds, about 1,900 cows, and we did 20 cows in each herd. So what I'm looking here is multiple cut points from 2.15 down to 1.75, and I just put in the average prevalence of subclinical hypocalcemia. Obviously, it went down from 61 at the high cut point down to very few here. So what's our alarm level, or what's our goal? Well, we get to decide that. I went with the 80th percentile of the herds in the study, meaning we want to be in the top 20%. That's one way to approach this. You get to decide that. But we would say, all right, if you want to be on the good end, you can only have 45% at this cut point, and you shouldn't have any at that cut point down there. It's a little abstract, so I'll show you how I report the data graphically to the herds. These are the cut points down here. These are the herd prevalences of subclinical hypocalcemia. So I put the goals on there in the bar graph, and I'm going to show you data from a real herd. This is what they had. So I show their data. We're over this goal, over this one, over. So that would tell us how this herd would compare across cut points to expected goals. I do think we have to stop obsessing about cut points. And doing multiple cut points helps us with that. We need to understand the biology. Good. But when we get to the herd, I think it really helps just to do multiple cut points. If we, as a veterinary profession, keep changing the cut point, the dairy producer and the practicing veterinarian loses confidence in the whole testing approach. I've seen this over and over and over again. Now, the difference between the cut points might be very small and biologically insignificant. But yet, when this happens, the dairy producer loses confidence. If we do multiple cut points, all arguments are resolved. So I like this approach for the field. And I can tell you from experience, I've seen some herds that do badly here and well down here. And I've seen other herds that do well at the higher cut points and poorly in the lower cut points. There is biological variation in our herds. All right, that's a lot about hypocalcemia. We have 3 more diseases. So let's go on to ketosis. It's not just fat cows, but it certainly can be a fat cow problem. That cow was very scary. She was so big and so heavy. We had to get a picture of her. What is ketosis? I find it most useful to say that ketosis is hyperketonemia, blood BHBA. And if it's elevated, we'll call it hyperketonemia, or just let that be our definition for ketosis, because the clinical signs are very subjective. And we've got an accurate cow-side blood test. Wouldn't it be great to have that great accurate cow-side calcium test? Well, we have the BHBA one. So we can define this disease that way. We've done this in research. We've had a little trouble in the US with the product and how we're going to do it. There are many options. The one we largely use is one called BHB Check from PortaCheck. It costs about $2 US dollars per strip, and almost identical performance to Precision Extra in a study that we did publish in Wisconsin. And I say that because Precision Extra in the United States went off the cattle market, essentially. They stopped marketing to veterinarians, and we can buy all the strips we want at the human price, which in the United States is almost $6 per strip. So we have switched over to this test, which performs very well. So we still have a good one. The prevalence, as we've looked across herds of hyperketonemia, is about 17% of our cows. The incidence is about 40%. So I just did epidemiology, because there's a difference between prevalence, the number of cases at any one time, and incidence, the number of cows who get the disease sometime in early lactation. And across several studies, we found the relationship between incidence and prevalence is in that 2 to 2.5-fold difference. If you remember your epidemiology, what crosses from prevalence to incidence is duration. So the duration is pretty steady on this particular disease. In fact, one of our studies, we showed it's about 5 days. It's the average duration of hyperketonemia. Okay, so what's the cut point here? I almost hate to bring up the word, cut point. Here we go. But we've been a little more settled on 1.2 millimole per liter in academia and in the industry. That's the most common one. There's been some variation. If you look at the literature, it certainly depends on what you're looking at, whether it's milk, disease, or removal risk. You'll always get a little different cut point. However you go, days in milk is probably important here, and we have not characterized that, but it does affect the BHB. I've seen people do between 1.0 and 1.4, again, a pretty narrow range. The best approach here would clearly be multiple cut points, multiple alarm levels, and we have not developed those at all yet. But I think that's a very attractive concept, but I'm biased because that's what I got started on. Okay, what test do we use? I've talked about the blood test. That is indeed our standard test that we want to be using. There are milk tests out there. And milk BHBA is only moderately associated with blood BHBA. The correlations are not good between those. And there's a simple physiological reason. The udder, when presented with BHBA taken up from the blood, can either metabolize that BHBA, probably turning it into milk fat, or excrete it. But it's not a direct excretion path. Excretion of BHBA varies by metabolic state of the cow. Milk data can be misleading. Blood BHBA is what the cow experiences. What she excretes in the milk depends very much on how much she metabolized. So, do we not use milk tests? Absolutely, that's not what we want to do. We want to use them, but we must understand their limitations. We often pair this with monthly herd tests, And I think we get very good herd level inference with those. Still not as good as doing a lot of blood tests, but we get good inference on that. As we use milk testing, and working with my colleague at Wisconsin, Dr. Heather White, we learned that if we wanted milk to be a little better associated with blood BHBA, we had to take all the test day information and put it into a big model. So we actually have developed a system that is commercialized in Wisconsin, where we predict blood BHBA from milk parameters. It's not just milk BHBA. It's not just milk acetone. It's parity, it's days in milk, it's milk yield, and those milk test results. It certainly increases the accuracy, sensitivity, and specificity of that compared to the blood. You can use milk fat protein ratios, even to the point of in the parlor, every cow, every milking. Okay, those give some herd level inference. This test was developed with that in mind. From the beginning, those authors said this is not an individual cow test. It's still not an individual cow test. It's a herd level test. So we are not applying this at the cow level, but it has some value. Urine acetoacetate, or the traditional urine test, has some value. You can look at lots of data on sensitivity and specificity. The main problem here, besides a little lack, particularly in sensitivity, is you got to get the urine sample, which can be a challenge. So what are the negative effects of subclinical ketosis? Classic effect, even in the subclinical form, is decreased milk yield. Many studies showing 3 to 7% reduction. A large study that I did with Dr. Jessica McCart, joint study with Cornell, we found that as BHB went up, so every 0.1 millimole per liter increase in blood BHBA reduced milk yield by 0.5 kilogram. So if you take the lowest level of penalty on milk yield, which would be 1.2, just barely subclinically ketotic, compare that to 2.4, that's 6 kilograms of milk different. So very strong relationship of more milk drop as the blood BHB goes higher. Some studies show no effect of ketosis on milk yield. So maybe the hyperketonemia was less severe in those studies because we know it has to be more severe to get the bigger milk yield losses. The other thing we've shown is early detection, early treatment of ketosis really minimizes the effect. And so herds have the option actually to minimize the impact of this ketosis. I'll show you more on that later. Other things you've seen, most of this is from the joint study that I did. We had about 1,900 cows, over 900 cases of ketosis. We used 11,000 of the precision extra strips in that study. Threefold more likely to be removed from the herd if they were classified as subclinical ketosis, over 1.2. Many studies show this very strong relationship between ketosis and DA. It's been one of the wonderful things we figured out about 20 years ago. It just keeps going. Cows definitely, many of them get ketosis before they get a DA. Paired first service conception, our cows were 0.6 times less likely to conceive. But other studies have shown pretty inconsistent reproductive effects with ketosis. The earlier studies usually showed it, the later studies don't. Our explanation for that is pretty simple. We are using ovulation synchronization programs now. And they take the sting of ketosis right out of reproduction. You use a good ovulation synchronization program, it doesn't matter if they're ketotic or not. And because what do ketotic cows do? They don't cycle and they don't display estrus very well. And we just force the issue by doing the OVSync programs. So I think that's why we're seeing this. I think biologically, especially as it gets higher, it definitely reduces reproduction. So as I hinted earlier, early detection and treatment, outside of good prevention, which we all know is important, but early detection and treatment, this disease, we have this very useful option. So we have a cheap test, so we could do routine BHBA testing. We treat the positive ones with 300 ml of oral propylene glycol once a day until their hyperketonemia resolves. Averages about 5 days. What happens? We increase milk yield. If we do that, we pretty much get back what we might have lost, not quite. We reduce the risk for removal over 2-fold. We reduce the risk of DA 1.6-fold. and we increase the risk that she will conceive at first conception if we do early detection and treatment compared to ketotic cows that we did not treat in this study. Very powerful approach. So those are my comments on ketosis. We're moving toward diseases where our knowledge base is a little less. So here we go, hypomagnesemia. This is a beef cow, because we don't see much of this in dairy. My world is dairy. Okay, so I don't see much of the clinical form of hypomagnesemia. I'm sure many of you in the room do see that in your pastured herds, beef and dairy. And you know a lot more about this disease than I do. But we know your risk is much higher. Just a few interesting points. We don't have a lot of new information on this disease. But clinical cases are usually hypocalcemic as well as hypomagnesemic. And often for cows to show clinical signs, they have to have both problems. So we're often treating with some calcium as well as with some magnesium. What I'm mostly interested in, I wish I had data to show you, but would be the subclinical form of hypomagnesemia in well-managed dairy herds, where we would do this herd level blood work like we might do for calcium. What's the cut point? We don't know. Maybe a little preliminary data around, less than about 0.82 millimoles per liter. Don't know the alarm levels, maybe less than 10% well-managed dairies. We'd really like to know this. I think it would be a very interesting area. I would encourage anyone who wants to get money and work on this to please do it. It would be a great thing for future research and development. So that's what I have on hypomagnesemia in this big overview talk. We will finish with hypophosphatemia, something that we do see in cows with intensive management. I want to make the point first that primary hypophosphatemia is rare. Even though nutritionists have lowered dietary phosphorus to reduce pollution, great thing. But cows still have plenty of phosphorus in their diet. This is not a primary disorder. It doesn't mean the diet was deficient. So why do they get it? They get hypophosphatemia because they were hypocalcemic first. So when you measure cows with hypophosphatemia, 90% of them are hypocalcemic. So it may not be all of them, but it's an overwhelming majority of cows develop this condition secondary to hypocalcemia. It's a normal part of hypocalcemia. Phosphorus will drop because PTH, which is very high in hypocalcemic cows, causes renal excretion of phosphorus to conserve calcium. These cows have a hypomodal rumen. So their salivary phosphorus, which is in very large amounts, just pools up in the rumen, and it cannot be absorbed from the rumen until it moves to the small intestine. So when we correct the hypocalcemia, the PTH goes down, the kidneys stop excreting the extra phosphorus, the rumen starts to move, the phosphorus moves to the small intestine, and this condition usually resolves. So that's what generally happens. But some of these cows don't resolve. Now, another interesting point, so then you might think, if we treat hypocalcemia, should we add phosphorus? And it doesn't help. If we add IV sodium phosphate to the treatment for clinical milk fever, it doesn't improve the outcome. The cow metabolically says phosphorus, not a big deal, calcium important. The phosphorus will take care of itself, and it almost always does. But in a small percentage of our clinical milk fever cases, the phosphorus remains low after the hypocalcemia is corrected. So they may stay down even below 0.3 with a normal of 1.3 to 2.6. If you do this, be careful. You want to use the tail vein blood for this testing, not the jugular vein, because the salivary glands harvest a lot of the phosphorus to make that salivary buffering. So we actually need to go to the tail vein, but we often want to sample from the jugular because that's where we're given the IV to treat this cow. But it's going to be a little bit off. If you get that blood from the jugular vein, it'll be a little bit too low. Why do we get these persistent hypophosphatemias? And we don't know for sure. Maybe Walter or others in the room know much better about this than I do. My clinical impression is those are cows that are not hypocalcemic, but we really didn't restore GI motility yet. So the salivary phosphorus remains in the rumen, especially if these cows remain recumbent. And what we see is when we manage down cows well, which means floating them, putting them in a tank of water and getting them up, many of these cows, even if you drain the water out, they go back down and they stop eating. And when you first put them up, they eat. And when they eat, their phosphorus almost always is restored. So I think we get motility going when we get these cows up. So I think it's very much related to prolonged recumbency. Please manage these cows well. So does this hypophosphatemia contribute to their prolonged recumbency? That's still unclear. It is still controversial. We know that phosphorus may contribute to muscle strength. But my impression and the impression of others is the effect is small to none, probably, on this. So should we treat those cows? Yes, with caveats. Don't neglect other problems and treat with oral phosphorus, please. IV is not that helpful. For these cows, it's really an oral treatment is important. So that's my overview of these diseases.